Hi everyone. We're gonna do general surgery synopsis today, like the little points, and we're gonna try to cover the whole thing. But first, we're gonna set our timer to 25 minutes because we're gonna do Pomodoro. And here we go. Starting with the embryology, we have thyroid gland is developed as a median thickening. So this is our tongue, is a foramen cecum. It's a remnant, and basically, we have thyroid starting, it develops as a median thickening like this, and then it travels down and forms the thyroid gland. So it's actually endoderm in nature or endoderm in origin. However, we have parafollicular C cells that contain calcitonin inside it. This is a whole thyroid gland. We have parafollicular cells, C cells. They are derived from mesoderm. So we can say that it's endomesoderm in origin, which is from the ultima brachial body. I'm going to show you the diagram and everything. Just let's just cover the embryology part of it. Now the connection of the median diverticulum present between the first and we have pharyngeal arches as we are little we, little fetuses, or what do you want to call embryo. Uh, this is a median. The connection of the median diverticulum, it's present between the first and second pharyngeal arches. So here's a median diverticulum with the pharynx in terms of is termed as thyroglossal tract. So we have a thickening arising from here, arising from the above and joining here. I'm sorry. We have a thickening here, and it grows down to become thyroid gland, and this is basically thyroglossal tract. And the site of its connection with the epithelial floor of the mouth is marked by foramen cecum that we covered here. Foramen cecum. So its connection is with the epithelial floor of the mouth, except that the distal part of the part that differentiates into pyramidal loop of the thyroid, and the rest of the duct disappears. So sometimes we see, like this is thyroid gland, this is isthmus. We have a pyramidal loop like this. It's a butterfly shaped organ. Of this thing. This sometimes this the remnant of the thyroglossal tract remains as a pyramidal lobe, and it can arise. It can arise a cyst, which we call thyroglossal cyst. Now let me just cover the. Um, so mm, this is the book that I follow. So we're gonna search for thyroid 453. 453. Yes. So here we are. the trachea, this is the thyroid, the esophagus, and important relations, development. So thyroid gland basically refers to the median downgrowth of the column of the cells from the pharyngeal floor between the first and second pouch or arches, subsequently marked by the foramen cecum. The canalized column becomes the thyroglossal duct, which is displaced forward by the development of hyoid bone and displaced forward, like it comes forward, and the duct bifurcates to form thyroid lobe, and a portion of duct forms a pyramidal lobe. So this is the anatomy. This is the development part. We're just gonna look at the pictures. This is a one third tongue is there, foramen cecum is there, two-third part of the tongue. This is a tract. This is a higher bone, makes it come forward. And this is the pyramidal lobe and lateral lobe of the thyroid, ectopic sides. And in like um, coronal view, we have this tongue, this foramen cecum, this hyoid bone. This is a duct, the whole duct. This is the cartilage and parathyroid. And then, oops, yeah, parathyroid and thyroid and pyramidal lobe is there. Thyroid gland. What else? What else? This the this is actually lingual thyroid. Posterior one that. This is actually lingual thyroid. What else? These are all the things that we will like see later on. But yeah, cool stuff. So yeah, coming back to it, we have the anatomy part to learn. So anatomy of the this thing. The thyroid gland actually lies opposite to the vertebra, which is 5, 6, 7 cervical vertebra and first thoracic vertebra. Parathyroid glands are actually related to the posterior border of the gland. So this is a gland, though posteriorly, here they are superior and here they are inferior. If we look from posterior side, the isthmus basically lies 2 to 4 of the tracheal rings. Sometimes the third conical lobe, pyramidal lobe, extends from the upper part of the isthmus towards the hyoid bone that we have covered. Thyroid gland is covered by two capsules. There is true capsule, and false capsule. True capsule is called as fascia propria. Fascia propria. And false capsule is basically derived from the pretracheal layer of the deep cervical fascia. Its thickened portion on the posterior medial aspect of each lobe is called ligament of Berry. So if we look at the thyroid gland, it's not given here. Let me head and neck, head and neck. We should probably have it somewhere here. Um, I don't know if we'll find it. Let's okay. Contents black structures in the neck. So 140. Oops. 140. Page 140. Yeah, should be here. 140. 153. We have from 140. Yes, yes. So, so this is the thing. This actually thyroid. This is a false capsule. This capsule is false surrounding it, and it's derived from deep cervical fascia. It's derived from deep cervical fascia, and 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 posterior medial. This is the posterior and medial side. We have ligament of Perry, and bone vita. It extends from posterior medial border of the cricoid cartilage. So, so we have like the cartilage, cartilage is a part of it's a cartilage of larynx. It extends from posterior medial border. So this is how cricoid looks like. From the posterior medial border, it extends and attaches to the this thing thyroid. Just gonna clear. So there we go. Oops, 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 oops. Yes. So we have this true, false, fascia propria. And the thyroid actually moves with the deglutition due to its attachment with the larynx and trachea as follows. So ligament of Berry on the sides, because of the ligament of Berry, it moves. Posterior lamina also of the pretracheal fascia is there. Pretracheal fascia, and this fibromuscular slip known as levator glandulae thyroid. Levator glandulae thyroid. So we have ligament of Berry, we have pretracheal fascia, that posterior lamina of pretracheal fascia, and we have levator glandular thyroid. These are the three structures that helps in the movement of deglutition. Now we have atrial supply. It's a superior inferior thyroid artery and additional supply of thyroidema artery. We can do it from here. Anatomy part. We have superior thyroid artery. We have inferior thyroid artery. This is superior thyroid artery. And then we have inferior thyroid artery. We also have a thyroidema artery, which is either if it's the right side, it will arise from the brachial. मम्मा मलाई तो नहीं है ना मलाई मलाई तो नहीं है ना अब वो आपने लास्ट टाइम इतनी सारी डाली थी उसमें
वो बचा दूध था ना, ज्यादा था नहीं, उसमें डाला नहीं था, तब भी तुम्हारा पहले ही निकाला था वो। गर्म करने के बाद ऐसे थोड़ा आ जाता है।
अच्छा, बहुत
मलाई
ज़्यादा
मुझे
था।
नहीं देता।
ठीक है। Okay. So now we have superior thyroid artery and we have inferior thyroid artery, and we also have thyroidema artery, which is, if it's from right side, it will arise from brachiocephalic trunk, or if it's from left side, it will arise from arch of aorta, because the brachiocephalic trunk is only on the right side, right? So we have that. Now venous, we have superior middle thyroid, which drains into the internal jugular, and we have inferior thyroid vein. What's the structure? Superior, medial, middle. We have they drain into internal jugular vein, and we have inferior thyroid that drain into vagus cephalic vein. Cephalic vein. Okay, there. And now, then we have nerve supply, which is a sympathetic supply from the superior, middle, and inferior cervical ganglion, and parasympathetic supplies from the external. Like we have nerve supply, me. We will either have sympathetic supply or parasympathetic supply. So in sympathetic supply, we have superior, middle, and inferior cervical ganglia. Superior, middle, and inferior cervical ganglia. And in parasympathetic, we have the vagus nerve, which gives out branches, external and recurrent. So these are the two branches. Now we can come to physiology part of it. But I kind of already finished it. Um, just a recap. So normal T4 serum is basically 4.5 to 11 micrograms per 100 ml. But T3 count in plasma is 100 to 160, although that's less, so it's nanogram per 100 ml. So these are the things. And thyroxine basically are protein bound, either protein bound or free in form. So majorly it's protein bound. Free are very less, like 0.004 microgram per 100 ml. Also, like T4, it's 99.9% bound to plasma, and T3 is 99.5% bound to plasma. And minimum daily intake of iodine we have to remember is 20 micrograms. Also, daily intake of iron is also 20 milligram, and for folic acid it's 100 micrograms. Mm, okay, what else? What else? What else? Granular treatment. We can directly come to I've done all of this. Okay, so just let me. I'll just revise what all I have done. So treatment and simple goiter. Treatment of simple goiter is um, there is administration of thyroxine with the dose of 0.3 mg per day for few months. For few months we have to give, and then we have to reduce the dose to 0.1 mg per day for few years. So This nice. How much time have I left? Okay, 5 minutes. I'll eat in 5 minutes. Okay. Uh, so, so basically, surgical treatment for cosmetic reasons, if we are doing, or there is obstructive symptoms, then we have to give L-thyroxine. L-thyroxine we give. There is pretribal myxedema, which is like the mucin like deposit on the lower part of the leg. And we've done this. LATs is long-acting thyroid stimulators. Yeah, of course. Papilloedema or corneal ulceration, exophthalmometer, apparent or true. Apparent exophthalmos is mainly caused by sympathetic nerve irritation. Apparent or true, which supplies the Miller's muscle, the unstripped muscle fiber, and the levator palpebrae superioris. Okay, so the eye signs that we see in Graves' disease shows exophthalmos, which can be apparent or true kind. So in apparent, we have mainly due to sympathetic nerve irritation, which supplies the Muller's muscle. Muller's, it's a Muller's muscle, which is unstripped muscle, and levator palpebrae superioris alveus. These are the two kinds. Let's just quickly check for what they mean, if if it's in the text. Mm. Ooh, okay. Let me. Yeah. So lid retraction here. The upper eyelid is higher than normal, and the lower eyelid is in normal position. It is due to muscle part of the levator palpebrae superioris, which is a Muller's muscle, is a sign of thyroid oxidosis, not a sign of exophthalmos. Okay. So parent is basically it's not exophthalmos, and that's why it's apparent. It's not exophthalmos. It's apparently exophthalmos, and it is because of the eye sign. It's because of the this thing. It's the sympathetic overactivity is there, and spasm occurs. Sympathetic overactivity in the Miller's muscle, which is LPS only. Lid lag. Oops, lid lag. So so we do have we do it does look like exophthalmos, but it's not. It's apparently exophthalmos. Now, progressive exophthalmos occurs due to liberation of special pituitary hormone called exophthalmos producing substance. So, if we have pituitary secreting um, exophthalmos producing substance. Exophthalmos producing substance. So, progressive exophthalmos occurs due to that. Then we have different kinds of eye signs. One is von Graffi, lid lag, Joffrey sign is basically to when we ask them to look upwards, there's no wrinkling on the forehead. Moby sign is failure to converge the eyeballs. Dalrymple sign is basically the upper sclera is seen due to retraction of the upper eyelid. That is Dalrymple, and Stilvagus. There is an absence of normal wrinkling or this staring look. So Stelvax, about 30% of the cases of the Graves' disease have circulating antibody against the gastric parietal cells. Okay, okay, okay. Just let me do this bit. Covered our time. 30% of the cases of Graves' disease have antibody cross reaction होता है because of the same kind of proteins on the surface of the cells. So gastric parietal cells are also affected. Gastric parietal cells are also affected. A high titer of thyroid antibody is found in one third of the cases. So one third of the cases, which is around 30% only, antibody against the gastric parietal cells. So that's about it for this session.